Good afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on alcohol risk and policy, epidemiology, and outcomes of alcohol-associated liver disease in adolescents and young adults. This is part 3 of a 5-part series focused on alcohol-related risks and policy. My name is Dr. Erin Hoban, and I am a senior scientist at Public Health Ontario, and I have the pleasure of moderating today's session. To start today's session, I wish to acknowledge the land on which Public Health Ontario operates. It has been the traditional land of many distinct nations, including the Huron-Wendat, Seneca, Métis, Haudenosaunee, and Anishinaabeg, specifically recognizing Treaty 13 signed with the Mississaugas of the Credit First Nation. I am grateful to have the privilege to work on this land. Before introducing our presenter, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session, and we really do encourage questions, so please enter them in the Q&A pod and we'll get to them. A discussion and question period will follow the presentation. If at any point during this presentation you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I do not have any conflicts of interest to disclose. It is now my pleasure to introduce the speaker for today's presentation, Dr. Jennifer Fleming. I saw Dr. Fleming present a snapshot of this work a few months ago at a CIHR webinar, and it was a very powerful presentation. So I'm just thrilled that Dr. Fleming was interested and available to present today. Dr. Fleming is an associate professor of medicine and public health sciences at Queen's University, whose research program leverages Ontario administrative data to evaluate the epidemiology and outcomes of patients with chronic liver diseases and cirrhosis. Her research has been supported by the Canadian Institutes for Health Research, American Association for the Study of Liver Disease, the American Gastroenterological Association, and the Canadian Donation and Transplantation Research Program. Dr. Fleming is an associate editor of the American Journal of Gastroenterology, chair of the Guidelines Committee of the Canadian Association for the Study of Liver Disease, and is a member of the American Association for the Study of Liver Disease Women's Initiatives Committee and the Canadian Task Force on Preventative Health Care. So without further ado, I'd like to pass it over to Dr. Fleming, please.
Great. Thank you so much, Dr. Hoban. And I want to thank all of the attendees for joining us today for my talk, which is going to be reviewing the epidemiology and outcomes of alcohol-associated liver disease among young adults. So I do not have any conflicts of interest here. And then there is a disclaimer here related to the information that I'm going to be presenting. So these are the learning objectives that I have for this talk. So the first is to understand the differences between high-risk alcohol consumption and alcohol use disorder, where I'm then going to be describing the effects that alcohol has on the liver. And then we're going to appreciate the diverse spectrum of alcohol-associated liver disease and an approach to treatment. I'll then review some data from Ontario describing the epidemiology and outcomes of alcohol-associated hepatitis among adolescents and young adults in relation to changes in alcohol policy, as well as COVID-19. And then we'll end to discuss potential policy implications related to alcohol in our population. So the first section of the talk, I'll be talking about the epidemiology as well as terminology related to alcohol-associated liver disease. But to begin and set the stage, I just wanted to make sure the audience is aware that the WHO has identified that alcohol misuse is a leading global cause of morbidity or mortality and is responsible for up to 3 million deaths annually across the world, in addition to substantial morbidity. Importantly, alcohol is the leading cause of premature mortality and disability in those aged 15 to 49. And consequently, the disadvantaged and vulnerable populations carry the highest burden of alcohol-associated death as well as hospitalization. So I wanted to make sure that the audience is aware of these distinct but related conditions. The first is high-risk drinking, and the second is alcohol use disorder. So when I refer to high-risk drinking, this is defined based on the quantity of alcohol which is associated with alcohol-associated liver disease. And this is really determined clinically based on the history that a clinician gets from either the patient or the caregivers. And high-risk alcohol drinking differs between sexes, whereas males are at risk of alcohol-associated liver disease at quantities greater than 30 grams per day or more than 210 grams per week, whereas it is lower in females at greater than 20 grams per day or more than 140 grams per week. And so most individuals don't necessarily know how to quantify their alcohol consumption. And so 20 grams to alcohol is difficult potentially for people to be able to disclose. So when we talk about 10 grams of alcohol, this is considered one standard drink. And at the bottom there, I have a pictorial representation of what one standard drink is. So for example, one standard drink is 5 ounces of wine or 1.5 ounces of spirits. But importantly, within Canada, there is no mandatory labeling of alcohol content in Canada. And so even though there are recommendations or there's some understanding about what quantity of alcohol puts people at risk of alcohol-associated liver disease, unfortunately, it is very difficult for individuals to understand how much alcohol they are consuming. This is in contrast to alcohol use disorder. So unlike high-risk drinking, where we quantify alcohol consumption, alcohol use disorder is defined based on the behaviors and the consequences of the alcohol consumption. And this is diagnosed based on the presence of 2 or more of the DSM-5 criteria if an individual has had these over the past year. And then what we can do is we can determine whether an individual has mild, moderate, or severe alcohol use disorder, depending on the response to the questions from the DSM-5. What is really important to understand is that there is a great overlap between individuals who have alcohol-associated liver disease and alcohol use disorder, anywhere between 30 to 50%. But it's also very important to understand that among patients who have alcohol-associated liver disease, they may not have alcohol use disorder. And subsequently, individuals with alcohol use disorder may not have underlying alcohol-associated liver disease. So although they are related, they are distinct conditions. When we look at alcohol use within the Canadian population, this is based on data from the Canadian Community Health Survey, which was most recently updated in 2017. And in Canada, any alcohol use within the past year occurs in approximately 75% of our population. But when we look at the proportion who engages in high-risk drinking, who would put them at risk of alcohol-associated liver disease, that is 20%. Unfortunately, the Canadian Community Health Survey does not give us exact data on the prevalence of alcohol use disorder. But if we use data from the United States, if our population is similar, that is usually present in approximately 5% of the population. So there is at least 1 in 5 individuals within Canada on any given day who are participating in high-risk drinking and at risk of developing alcohol-associated liver disease. When we look at high-risk alcohol use, it also depends on the age group. So this again is data from the Canadian Community Health Survey, where they looked at past high-risk alcohol use within Canada. And we can see that the highest proportion who participate in high-risk alcohol consumption are young adults aged 19 to 24. Within the Canadian Health Survey, when they looked at trends over time and they looked at differences between males and females, high-risk drinking actually decreased by 10% in males, but increased by 30% among females. And we know that the liver is the most common end organ affected by high levels of alcohol consumption, which is why we are focusing on alcohol-associated liver disease in this presentation today. So in the next section, I'm going to walk you guys through the clinical spectrum of alcohol-associated liver disease, and it is very heterogeneous. First, I want to make sure that people understand that it's not just the quantity of alcohol that consumed that puts somebody at risk of liver disease, but there's also other factors that can increase the risk of alcohol-associated liver disease. So for example, you could have 2 individuals who consume the exact same quantity of alcohol. Some may develop alcohol-associated liver disease and some may not. And that's because there's more at play than just the quantity. We know that there's a genetic predisposition to alcohol-associated liver disease, and there have been genes that have been identified. I also briefly mentioned female sex. We know that women have less alcohol dehydrogenase in their body than do men, and this is the enzyme responsible for alcohol metabolism. Females also have a lower content of body water, and the liver is a sex hormone specific organ and responds to the effects of estrogen and testosterone. If somebody has another underlying comorbid liver disease, such as chronic viral hepatitis B and C, this can increase the risk. It also can depend on the type of alcohol and the pattern of alcohol consumption. So studies have suggested that alcohol-associated liver disease is less likely to develop in those who exclusively drink wine versus those who drink beer and spirits. It's also been shown that the risk is increased for those who drink outside of meal times or who are participate in binge drinking. Obesity is also a risk factor, as is previous bariatric surgery and smoking. So it's more than just the quantity. There's other patient-related factors that can increase the risk. So how does alcohol actually damage the liver? Well, alcohol consumption leads to increased fatty acid accumulation and deposition in the liver. And this can happen by many different pathways, but the final common pathway is that fatty acid accumulation occurs in the liver, and individuals develop what we call hepatic steatosis, or fat buildup within the liver. Once hepatic steatosis is established, damage to the liver cells occur in multiple different ways. The first is by the Kupffer cells. So Kupffer cells are macrophages which live within the liver. And when they are activated in the presence of alcohol byproducts, they secrete inflammatory cytokines to create an inflammatory response. There's also activation of stellate cells. Stellate cells within the liver are responsible for lying down fibrous tissue. And so when there's activation of these cells from alcohol byproducts, they produce fibrosis and scarring, which can lead to cirrhosis, which we'll talk about in the next slide. There's also an autoimmune response where autoantibodies can be produced by the body in response to this. So all of these different pathways lead to inflammation as well as fibrosis in the liver in the setting of heavy alcohol consumption. So in this slide, I'm going to walk you through the spectrum of alcohol-associated liver disease. So on the left-hand side here, we have a high-risk alcohol consumption in an individual who initially has a normal liver. We talked about the different risk factors that individuals can have in this setting. And then what can happen in the setting of high-risk alcohol consumption or prolonged ongoing alcohol exposure is that typically over 10 to 30 years of regular exposure with this slow chronic injury, individuals develop steatosis, which I mentioned is fatty acid accumulation in the liver. If inflammation is also present, we call this steatohepatitis, where there's steatosis as well as inflammation, and this can eventually lead to fibrosis or scarring of the liver. If this pathway continues over long periods of time, the amount of scar tissue that develops eventually leads to somebody developing cirrhosis of the liver. Once you develop cirrhosis of the liver, you're at risk of developing liver failure, at which point in time, unless if there's no chance for recovery, either somebody will require a liver transplantation or eventually will die from underlying liver disease. What I want to highlight is this other entity of alcohol-associated liver disease called alcohol-associated hepatitis. And in contrast to the slow chronic injury that I described above, alcohol-associated hepatitis is a more severe, rapid, acute liver injury that can occur in a much shorter time period within months to years of very heavy alcohol exposure. Once somebody develops alcohol-associated hepatitis, they may go on to more rapidly develop fibrosis, as well as cirrhosis. And some individuals with alcohol-associated hepatitis will develop liver failure very rapidly, even without underlying cirrhosis, which can put them at risk of requiring a liver transplantation or death. One of the unique things about the spectrum of alcohol-associated liver disease is that in the setting of alcohol abstinence, there is the opportunity that the liver can recover. And we have seen this time and time again in individuals with severe alcohol-associated liver disease who are able to maintain abstinence. Recovery can occur over months to years. And people are able to improve their liver function because the liver is one of the only organs in the body which is able to regenerate themselves. So when I talk to patients and I'm trying to describe this to them, I use a car analogy, and I find that this gives people a good idea of what I'm talking about. So when we talked at the beginning about the slow chronic injury, the first thing that happens is alcohol-associated hepatic steatosis, which is just fat buildup in the liver. It's kind of like getting a little scratch on your car. There's really no long-term damage. You can easily fix that with abstinence, and the car is still functioning and working. When people progress to alcohol-associated steatohepatitis, where there's steatosis as well as inflammation in the liver, this is a bit more of a severe injury, but it can be fixed and the car is still working. And so this is all potentially reversible. When we talk about alcohol-associated cirrhosis, this is chronic long-term damage from long-term exposure to alcohol, where the car might still be able to function, but because of all the long-term damage, it's at very high risk of breaking down or needing to trade your car in for a new one. When I talk about alcohol-associated hepatitis, this is a car crash. This is the acute severe injury where there's an acute severe injury to the liver where it starts to not function. And the question really is, are we able to fix this car after the car crash, or do we need to trade it in for a new one? So I'm going to talk about the treatment of alcohol-associated liver disease. And really the cornerstone of management in all of those forms of alcohol-associated liver disease is abstinence. And the single most important predictor of long-term outcomes in patients who have alcohol-associated liver disease is whether or not long-term abstinence is able to be maintained. However, we know that this is a very difficult to treat chronic condition, and recidivism or relapse back into alcohol rates have been as high as 80%. And we have very little data on predictors that predict relapse. Some recent studies have suggested that those who consume very high amounts of alcohol or have very severe liver disease, those who are unmarried, who are smokers, and who have a short length of abstinence are more likely to relapse back into alcohol consumption after a period of abstinence. So how do we try and treat this, especially if people have underlying alcohol use disorder, as I've mentioned? So the treatment of alcohol use disorder is multifactorial, and it includes both medical therapy as well as behavioral therapy or cognitive behavioral therapy. And despite the high prevalence of alcohol-associated liver disease within our population, there have been very few studies which have actually evaluated the treatment efficacy or the outcomes of alcohol use disorder treatment among those who have advanced alcohol-associated liver disease. Most of the times, these studies which look at alcohol use disorder exclude individuals who have underlying advanced liver disease. So when people have tried to look at whether or not patients with alcohol-associated liver disease are actually receiving treatment for their underlying alcohol use disorder, one study from the United States suggested that among patients who had alcohol-associated cirrhosis, less than 15% ever received alcohol use disorder treatment. But importantly, among those who did receive treatment, they had lower rates of liver complications, just again, highlighting the importance of abstinence and engagement in alcohol use disorder treatment for this population. When we talk about pharmacotherapy for alcohol use disorder, we need to be cognizant that sometimes the medications we use can be metabolized by the liver. And so these are the medications that we currently have in our repertoire in addition to behavioral therapy to treat underlying alcohol use disorder in patients who have alcohol-associated liver disease. Acamprosate is cleared by the kidneys, and therefore we are able to use that. And baclofen has also been studied in patients with advanced alcohol-associated liver disease, suggesting safety. Naltrexone is also approved for alcohol use disorder treatment. However, it is cleared by the liver. And so there is caution suggested in using this in patients with advanced alcohol-associated liver disease. However, recent studies are really suggesting that this medication is likely safe in this population. Gabapentin can also be used, and that's cleared by the kidneys, so something that we can use in our repertoire. However, we do not use disulfiram. This is also known as antabuse, which people may be familiar with. And this can have acute liver injury, and so it is not recommended for use in patients with alcohol-associated liver disease. For those individuals who have the most severe acute form of liver-related injury of alcohol-associated hepatitis or the car crash, there are other treatments that we need to be considering in this population. And that depends on whether or not your injury is mild or severe. And we determine this based on blood work when patients present for evaluation. So among those who have mild alcohol-associated hepatitis, If they are able to achieve abstinence, then short-term recovery within 90 days is excellent. Greater than 90% will recover without any long-term sequelae. However, among those who have a severe alcohol-associated hepatitis, not only do we need to achieve abstinence, but we also consider the addition of steroids to decrease the amount of inflammation that's happening in the liver. And these patients typically require hospitalization and sometimes intensive care unit stays. Short-term recovery within 90 days is much less in the setting of severe alcohol-associated hepatitis at 60%. And so among those who are not responding to our current treatments and who continue to progress to more severe liver failure, the two options at this point are either consideration for liver transplantation or, unfortunately, dying from underlying alcohol-associated liver disease. So in the next section, I'm going to be talking about some of the data that we've been looking at in Ontario, specifically looking at alcohol-associated hepatitis in adolescents and young adults. And so why are we looking at this population specifically? Well, we know based on previous data from Ontario that adolescents and young adults are experiencing the greatest increases in harms related to alcohol. This was a study that was published in 2019 by Dan Mirren and colleagues in the CMAJ, where they looked at individuals presenting to the emergency room only for alcohol-associated reasons. And they looked between 2003 and 2016 and showed that overall that the number of visits was 4 times higher in that study period. They noticed that women had much higher increase in hospital visits compared to men. And importantly, the highest increase was among young adults, where the emergency room visits due to alcohol increased by 175% during that time period. Around the same time, my study team was also looking at the epidemiology of cirrhosis and specifically looking at cirrhosis caused by alcohol-associated liver disease. And so what we did is we calculated the new cases of alcohol-associated cirrhosis in our population, and we stratified that based on when you were born, based on the colors down below. And then what we did is we took this data and we projected over the next 20 years and said, if nothing changes in how we're dealing with this, what are we going to expect? And you can see that the younger birth cohorts in blue, those born after 1980, are going to have a very steep, steady rise in new cases of alcohol-associated cirrhosis. What's important to note here is we were looking at alcohol-associated cirrhosis, which is really just the tip of the iceberg of alcohol-associated liver disease. And so one can imagine that if this is what's happening with respect to end-stage liver disease and cirrhosis, that there's going to be a significant population who is having other alcohol-associated liver disease harms. The other important thing to note is that when we did this, we based this on pre-pandemic patterns of epidemiology. And we very well know that the COVID-19 pandemic had an impact on alcohol consumption within our population. Data from Canada here looked at alcohol sales during the COVID-19 pandemic between March 2020 and June 21. And what these investigators showed is that alcohol in sales increased by 5.5% per month during COVID-19. My collaborators in Alberta were also concerned about alcohol use and alcohol-associated liver disease. And what they did in this study is they looked at the early COVID-19 pandemic between the early 2020 until September 2020. And they looked at hospitalizations for alcohol-associated hepatitis, or that very severe acute liver injury. And it showed that these presentations increased by 10% per month and were more often among younger aged individuals and those living rurally. So the other thing that we wanted to consider was how increasing availability of alcohol in Ontario has impacted rates of alcohol-associated liver disease, specifically among adolescents and young adults. So between 2002 and 2010, there was really no major changes to alcohol policy in Ontario. However, in 2011, expansion of alcohol sales began, initially into bookstores, movie theaters, as well as festivals. And we are all aware in late 2015 that there was expansion of alcohol sales in Ontario for the first time to grocery stores, where approximately 450 stores were participating. In late 2019, there was expansion of sales to LCBO convenience outlet stores. And in 2020, as a result of the COVID-19 pandemic, expansion of alcohol delivery and lowering of the minimal pricing for alcohol by 33% was instituted if it was purchased with food delivery. And this audience is probably aware that there's more changes coming to alcohol policy. And by 2026, there is plans for expansion of sales of wine, beer, coolers, and seltzers to over 8,000 convenience stores and big box stores across Ontario. So knowing this, we wanted to define the contemporary epidemiology and demographics of adolescents and young adults with alcohol-associated hepatitis from a diverse population during the changes to governmental alcohol policy, as well as the COVID-19 pandemic. And knowing that there was differences in alcohol use as well as susceptibility to alcohol damage between sexes, we wanted to define the association between sex and long-term mortality and the development of liver-related complications among adolescents and young adults who survived their first presentation of alcohol-associated hepatitis. So in order to do this, we designed a retrospective population-based cohort study here in Ontario, Canada, using the databases from ICES. So as you're all aware, Ontario has a large population of approximately 14 million and is very culturally and ethnically diverse, with 20% of the population identifying as recent immigrants or refugees. So what we did is we identified adolescents and young adults between the ages of 13 to 39 who had their very first presentation of alcohol-associated hepatitis either to the emergency room or to the hospital between 2002 and 2021. And we followed these individuals to the end of 2022. We identified somebody as having alcohol-associated hepatitis based on an ICD-10 billing code if it was listed as the primary diagnosis, either to the emergency room or the hospital setting. And what we did is we really wanted to exclude individuals who already had known very advanced liver disease. So those who already had a history of cirrhosis or liver failure or who required a liver transplantation were excluded. And we also excluded individuals who did not have a unique identifier in order for us to link them through the databases at ICES. So we really wanted to look at the association between sex and outcomes. So we dichotomized individuals, whether they were male or female. We wanted to look at overall mortality, and we had this data up to the end of 2022. When we look at cause-specific mortality, that data lags a little bit in ICES, so that was available into the end of 2018. We also wanted to look at which individuals were developing cirrhosis with or without decompensation or liver failure, which we were able to identify in the data, and we also wanted to see who required liver transplantation. The other demographics and social determinants of health that we wanted to look at were underlying medical comorbidity. We wanted to look at a history of healthcare encounters 2 years before they presented to hospital, specifically looking at healthcare utilization for alcohol misuse, substance use, as well as mental health conditions. We wanted to look at whether individuals lived in a rural or an urban setting. We were able to link to the immigration and citizenship database as well to look at individuals' immigration and refugee status. And we looked at neighborhood level social determinants of health quintiles, including income status, ethnic diversity, as well as housing instability. So what we did is we calculated the incidence or the number of new cases of alcohol-associated hepatitis in this young age group and compared it over time. And then we developed multivariate competing risk regression models to look at the association between female sex and overall mortality, where we considered liver transplantation to be a competing event. And we also looked at the association between female sex and the development of cirrhosis with or without liver failure, using death and transplantation as competing events. So this is how we formed our study cohort. So after all of our exclusions, we identified 3,340 adolescents and young adults who had their very first presentation of alcohol-associated hepatitis who did not have underlying advanced liver disease in the background. So these were individuals without cirrhosis. So the first thing that we did is we calculated the incidence of alcohol-associated hepatitis over time in Ontario. And you can see that on average, rates increased by 8% per year. Then we wanted to specifically look at the impact of provincial changes to alcohol policy on these rates. So we used the timeframe 2002 to 2010 as a background for the rates. Then when we looked at expansion into bookstores, the rate increased by 47%. When we looked at expansion into grocery stores, this increased by 136%. And then with the addition of the COVID-19 pandemic, rates of presentation for alcohol-associated hepatitis increased by over 200% during that time period. So next, we wanted to look at this population in more detail. So of those 3,340 individuals, the majority required hospital admission, 74%, whereas 26% were seen in the emergency room and discharged. What we did is we then excluded patients who had cirrhosis at their very first presentation. So when they showed up for hospital for the very first time with alcohol-associated hepatitis, they already had underlying cirrhosis, and this was present in 26% of these adolescents and young adults. So at the end, that left us with 2,374 adolescents and young adults who survived their first presentation of alcohol-associated hepatitis and who were at risk of developing cirrhosis during follow-up. When we looked at our outcomes, we looked at this yellow group here for overall mortality. So all of those individuals with their first presentation, regardless of whether or not they had cirrhosis. But when we looked at the development of cirrhosis, we only looked at those who did not have cirrhosis at baseline. So these are the demographics of the overall cohort. When we looked at them, 36% of them were female, and the median age at presentation was 33 years. You can see the youngest individuals within our cohort were 14 years of age. The majority had minimal underlying comorbidities, but within 2 years before their first presentation, many had already had healthcare encounters related to alcohol, either through the emergency room or the inpatient setting. A majority of them had underlying mental illness, and 1/3 of them had a history of substance misuse. When we looked at social determinants of health, we looked at it overall, and we also stratified it based on male and female. We can see that compared to the general Canadian population, more of these individuals lived rurally, and this was more common among females than males. The majority of them also lived in the lowest income quintile, which again was more common among females than males. When we looked at recent immigrant and refugee status, this was more common among males than females, and there was more males who lived in the highest ethnic diversity quintiles. And finally, equal proportions of men and women were living in the highest housing instability quintile. So this is a very vulnerable population who's presenting with alcohol-associated hepatitis. So first, we wanted to look at overall mortality. So we took this population of adolescents and young adults, and we followed them for an average of 5 years. And we also looked to see whether or not they got liver transplantation. And what we found is that over 5 years in this young group of individuals, 25% of them had died after this first presentation, and very few of them actually went on to receive liver transplantation. Of those who did receive liver transplantation, this was more often seen in males than it was in females. We then looked at rates of overall mortality over a 20-year study period, and you can see that the mortality was similar between males and females. And by 20 years of follow-up, so remember the median age of this group at the time they came in was 33, 20 years later in their mid-50s, 50% of them had unfortunately already died. When we looked at risk factors for overall mortality, although there was an association with sex, this confidence interval crossed the null, but factors that were associated with overall mortality were older age, being hospitalized at your first presentation, having cirrhosis or decompensation at the time you presented, living rurally, and having higher comorbidity. Like I said, we had causes of death of data available in a subset of our group. And when we looked at this, the number one cause of death in these individuals was liver-related, but liver-related deaths were more common among females than they were in males. The second most common cause of death were external causes such as injuries, accidents, suicide, poisonings, and these were more common among males than females. And the third most common cause of death were mental health causes, which was equal between the sexes. We then went on to look at the long-term liver-related mortality stratified by males and females, and we can see that women were more likely to have a liver-related death during follow-up than were men. Finally, we wanted to look to see, of those individuals who survived their first presentation, who did not have cirrhosis or liver failure at the very first time, who went on to actually develop cirrhosis and or liver failure during follow-up. So we followed these individuals for a median of 4 years, and at that time, 31% of individuals developed cirrhosis. 30% of those people actually had liver failure at the time that they presented, and females were more likely to develop cirrhosis and liver failure than were men. When we looked at death, these individuals, 20% of them died during follow-up, and very few of them received liver transplantation. This is a curve looking at the development of cirrhosis or decompensation stratified by sex. And you can see at any point in time, females were more likely to develop cirrhosis and decompensation than were men. And also importantly, the majority of individuals who did develop cirrhosis developed it within 5 years of their first presentation. When we then did adjusted analysis looking for risk factors for developing cirrhosis, females had a 47% higher risk of developing cirrhosis over follow-up than men. Other risk factors were older age, living in an urban residence, and having higher underlying comorbidity. And so the summary of this work shows that the incidence of alcohol-associated hepatitis is rising in adolescents and young adults, and death is occurring in up to 25% after a median of 5 years of follow-up. This young alcohol-associated hepatitis population is vulnerable in their social determinants of health, and we did notice sex differences in underlying sociodemographic factors. And although overall mortality after the first presentation of alcohol-associated hepatitis is similar between the sexes, females have higher rates of liver-related mortality than do males. And female sex is associated with an almost 50% higher risk of developing cirrhosis and decompensation among those who survived their very first presentation. And so I'm going to talk about some implications of this data. So I think this really should be considered a public health crisis, in that these young individuals are presenting with severe liver injury and are having substantial mortality. And really, unless efforts for early identification of alcohol use disorder and alcohol-associated liver disease in adolescents and young adults is prioritized, there will be considerable ongoing premature mortality in this young and vulnerable population. And efforts to reverse these trends will really require a sex-specific approach based on our findings. So I'm going to end with talking about some potential health policy implications of this. So when we take a public health approach, we always think about primary, secondary, and tertiary prevention. So in order to decrease the impact of alcohol-associated harms to adolescents and alcohol and young adults, primary prevention refers to limiting the exposure of alcohol to our population. Secondary prevention refers to the early identification and treatment of heavy drinking, alcohol use disorder, and alcohol-associated liver disease. And finally, tertiary prevention is the treatment of end-stage liver disease from alcohol. So within this context, for primary prevention, there should be considerations for changes in governmental policy. I've shown you data suggesting that each time there's liberalization of alcohol to our population, that rates of alcohol-associated harm to adolescents and young adults increase. And we know from other countries, such as the United Kingdom, that changes in governmental policy related to alcohol, such as changes in minimal unit pricing, can be effective at the population level. There also should be consideration of marketing as well as labeling. I discussed that really the Canadian population does not have a reliable way in order to quantify their alcohol consumption. And there's also lots of data suggesting that marketing is targeting these vulnerable populations, is specifically targeting young women. Public education onto the risks of alcohol use and the subsequent alcohol-associated liver disease needs to be considered, as well as access to mental health services and ongoing focus on the social determinants of health. When we talk about secondary prevention, we need to develop strategies to screen for high-risk alcohol use disorder, and alcohol-associated liver disease at the level of primary care. And we need to make access to alcohol use disorder treatment, specifically behavioral therapy, more accessible. We also need to consider a multidisciplinary approach between hepatology as well as addiction medicine in order to treat these individuals. And finally, from a tertiary prevention perspective, we need to have equitable access to liver transplantation for those who have severe alcohol-associated liver disease who do not respond to treatment. We need to engage these individuals with relapse prevention services. And we really need to look into alcohol use disorder treatment trials in those with advanced liver disease, as we know that this is the most important for long-term outcomes. So my final slide here is just kind of reinforcing some of these points and looking specifically at addressing disparities in alcohol use disorder treatment in individuals with alcohol-associated liver disease. From a clinical provider standpoint, systematic use of alcohol use disorder screening tools in clinic could be one strategy, as well as education of hepatology providers so they become more familiar and comfortable with treating underlying alcohol use disorder. From a hospital or an institution level, providing access to language and transportation services for alcohol use disorder and behavioral therapy will be key, as well as the ability to provide timely and equitable access to addiction medicine, social work, as well as psychiatry. From a research lens, we really need the field to design high quality studies to evaluate alcohol use disorder treatment in those with alcohol-associated liver disease. And we really need to prioritize inclusion of study participants who are diverse in age, sex, race, gender, and culture. And finally, from a societal perspective, we need to reduce the stigma associated with alcohol use disorder and alcohol-associated liver disease so patients feel comfortable presenting to providers with their concerns. And public education on alcohol use disorder and the outcomes of alcohol use disorder treatment also need to be considered. So in summary, alcohol-associated liver disease is a significant health threat, especially to our adolescents and young adults. Our adolescents and young adults with the most severe form of alcohol-associated liver disease are at high risk of dying or developing cirrhosis within 5 years of their first presentation. And governmental policy and public health intervention should be strongly considered in order to reverse these trends for future generations. And with that, I would like to thank you for your attention. I would like to thank ICS, and a special thanks to Maya, who is my analyst who works on all of these projects with me, and to my study sponsors. Thanks again for your attention.
Thank you, Dr. Fleming, for that very interesting presentation. We will now move on to the Q&A segment of this event to address some of the questions from our audience. Please continue to enter your questions into the Q&A pod. Please continue to put your questions into the Q&A pod, and we will be sure to get to them over the next 15 minutes. So the first question in the Q&A pod wants to thank you very much, Dr. Fleming, for your presentation, and they have two questions. The first, they're wondering if you could please define binge drinking, and the second, was loss to follow-up similar between males and females in the study?
Okay. So with respect to the first question about binge drinking, there's different ways that people describe this, but in general, it's consuming more than 60 grams of alcohol in one sitting is what's considered binge drinking. With respect to the loss of follow-up, so the good thing about the ICES databases are that we typically can follow everybody until they move out of the province. And typically that occurs in less than 1% of people every year. So we have very little loss to follow-up. So even if people move within Ontario, we can still follow them and see where they go. So it's only once they leave the province that we're not able to follow them.
Thank you. I was wondering, when you're having conversations about your research with others, has anyone raised the potential? So there are some researchers that are talking about some evidence that younger cohorts are starting to drink less alcohol. Has that been raised in any of the conversations, that perhaps the trend in higher levels of alcohol use are actually starting to reverse themselves among younger populations, and how, that actually might be a good thing?
Yeah, so there are some data when you look at kind of overall alcohol use or binge drinking, that younger cohorts are potentially not consuming as much as in the past. The one thing that I'm a bit concerned about, which I didn't kind of bring up in this lecture, is the types of alcohol that young individuals are drinking. So if you've noticed, there's been a shift that there's a lot of alcohol products that now contain a lot of sugar. And so you'll have ciders and all these fancy kind of sweet drinks that individuals are drinking. So the thing that I've actually been noting when I see these young individuals is sometimes they're drinking a similar amount, but they're drinking beverages that have a very high sugar content.
Mm,
And we know that sugar is just as damaging to the liver as is alcohol, because alcohol and sugar are metabolized the same way. So when your body has excess alcohol or excess sugar, it converts it into fat and it puts it in the liver. So I'm particularly concerned not only about the quantity that people are drinking, but actually the types of alcohol that people are drinking, and wondering whether or not the addition of high sugar content to the alcohol is creating kind of a perfect storm.
hmm. Thank you. Another question from the audience. Under the cause of death, you mentioned mental health being one reason, but saw suicide under the injury cause of death. Wondering what fits under the mental health cause of death.
Yeah, so that's a good question. So we basically divided up the causes of death based on what Statistics Canada does. And so when they have the accidental cause of death or the external causes of death, they put suicide under that umbrella. Now, obviously, individuals who suffer death by suicide, a lot of them probably have underlying mental health conditions. And so it's difficult for me to say what the actual mode of death was, because when you put cause of death on a certificate, it's kind of the encompassing condition which led to the cause of death. So it could have been it's hard for me to comment on that, but that's what the data is suggesting. So things that we would pull out from the data would be like schizophrenia or psychosis or things like that. So it's hard for me to really say what the actual mode of death was, but that there was a large proportion of individuals with underlying mental health conditions where whoever saw them at the time of their cause of death thought that that was the underlying cause. Sorry, I can't be any more specific than that.
Thank you. I found your slide showing the trends in alcohol-associated hepatitis and increasing liberalization of alcohol sales in Ontario. Super interesting. I was just wondering if you have thought about any alternative explanations for the increase in alcohol-associated hepatitis in young adults during that time
Mm-hmm.
period.
Yeah, so certainly our data can't do cause and effect. These are just circumstantial associations that we're finding. So certainly there are changes in the culture around alcohol use, and that differs between the sexes as well. I already talked a bit about the different contents or the types of alcohol that people are drinking. So drinking more kind of sugary beverages, which would make sense to me that the combination of the two of them are doing that. We know that there's been changes in marketing, and that alcohol companies are targeting kind of specific niches, and specifically young women. There's, another talk that I give looking specifically at alcohol use among women, and studies suggesting that marketing is specifically targeting this population. There's been the development of the mummy wine culture, and just a closing of the gender gap with respect to alcohol use. So certainly there's more going on here than just alcohol policy, but it's hard to ignore these trends in the setting of liberalization as well.
Thank you for that response. One of the audience members says, thanks for this comprehensive analysis. What would it take to be able to show this kind of data on an ongoing annual basis to show trends in relative real time?
Mm-hmm. So the good thing about ICES is that these data are updated almost in real time. The barrier to doing this on a regular basis would be funding in order to do it. So access to grant funding in order to do this. But certainly if you had the financial resources on an annual basis, you could be updating these all the time and looking at any changes and trends. The other thing you could do is you could look at specific regions within the province. Are there certain regions that are more affected than others? We already saw that rural residing individuals were more likely than urban residing individuals, but is that at a specific location? Could we actually find quote unquote hot spots where there seems to be kind of disproportionate increase, and should we be planning some sort of intervention within those communities? All of those things are very important, and all of things can be done within the data that we have if we're able to secure funding in order to look at that, which is what the team is trying to do.
Great. And this is a bit of a follow-up question that you somewhat already answered, but given the announcement in the province in December 2023 of the expansion of alcohol in 2026 to 8,500 corner stores, I was just wondering if there are plans to follow up on your current research over time, and maybe if you can talk a little bit about what you might expect over the next few years as alcohol sales sort of explode in the province.
Mm-hmm. So yes, this is something that I want to continue to look at and monitor, specifically related to these policy changes. And so the difficult thing is, like I said, there's so many different things that could be contributing to this rise in the population that it's hard to just say, okay, it's this, but it's or it's that. But I think, in my mind, the easier it is to gain access to alcohol, then the more people are going to use it, and that's been shown in other countries as well. And so I can't imagine that there's going to be anything that is going to stop these trends from continuing without major changes happening. So I'm very interested to see what's going to happen over the next 5 to 10 years.
Thank you. One of the audience members is asking if you could please speak to what % of the Canadian population is considered as having AUD versus high-risk drinking, especially in terms of Canada's guidance on alcohol and health and their definition of high-risk drinking.
Okay. So thanks for that question. So the data that we have from the Canadian Community Health Survey allows us to quantify high-risk alcohol consumption. So based on data from 2017, approximately 20% of the Canadian population is participating in high-risk drinking. Now, because alcohol use disorder is not based on the quantity of alcohol, but more so on the behaviors, those questions aren't asked in the Canadian Community Health Survey. So actually, if you look in the literature, we have very, very little data on the proportion of our population who has underlying alcohol use disorder. But what we do know is that there are data from the United States, and within the United States, approximately 5% of their population has underlying alcohol use disorder. So if you think that we're geographically and culturally somewhat similar to the United States, then the best estimate I would have would be approximately 5%. But again, we don't know.
Thank you. Another question from the audience. They're interested to know if the variable of adverse childhood experiences, often referred to as ACEs, was a variable that was also looked at in the analysis as a variable contributing to these trends.
That's a great question, and I really wish I could look at that. Unfortunately, the data in ICES, it's difficult to tease out whether or not an individual has experienced that, because most of the data within ICES are administrative billing codes, and we don't have access to patient level data. But certainly in my own clinical experience in dealing with patients with alcohol associated liver disease, I spend some time kind of talking about their history and the what's surrounding the alcohol use, and certainly adverse childhood events as well as interpersonal violence. Those things are very common themes, especially among women that I hear, as well as underlying untreated mental health conditions are something that I see very frequently in this population. So I would agree that if we could look at that, my suspicion is that there would be a strong association between those two.
Thank you very much, Dr. Fleming. It's time to wrap up today's PHO rounds. So again, thank you so much for presenting. I would also like to thank everyone who joined us for today's webinar. Everyone online, you can expect to receive a brief and anonymous PHO round survey for today's session. Please try and complete this to help us improve our programming. A reminder to everyone, the topic, the Ontario Public Health Convention, will be held on March 26th and April 3rd of this year. Registration is open. Please check out topic.ca for details. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you again, Dr. Fleming, for this very interesting and powerful presentation, and to everyone online, have a wonderful day.